next speaker is going to be Dr. Noreen Bukhari. She's an assistant professor in neurology and psychiatry. She did her fellowship in Parkinson's disease and movement disorders, and she will be speaking on functional MRI, brain activity in dystonia.
So thank you so much for the invitation. Thank you to Julie, and thank you for the Blepharospasm Society for inviting me to this excellent event so far. I've learned a lot myself about the patient population and the exciting treatments on the surgical side. So I'll be speaking a little bit about transcranial magnetic stimulation. So I really appreciate that Dr. Tag came actually before me, because he laid the landscape of what the field of TMS looks like for blepharospasm. And I'll be speaking a little bit about our use of TMS as a research device right now, but our hope is to translate it into clinical therapy for dystonias. And so the title was intended to reflect the paths that we have walked, as well as the future and the obstacles that we have to overcome to make this into a therapy. So I know that we have been speaking and focused mostly on blepharospasm, but in addition to blepharospasm, there are other types of dystonias. And so briefly here, I'm showing pictures of a few different types of dystonias, including focal hand dystonia, where patients may have difficulty during tasks such as writing or music playing. We also have patients with foot dystonia, so runners can develop dystonia during their running activities. And then we have patients who have generalized dystonia involving the whole body and trunk. The most common forms of dystonia are actually cervical dystonia, which are isolated dystonias and sporadic. Now, as we have well heard from a lot of our excellent speakers today, that there are botulinum toxin that is given as a treatment, and there are medications. But these treatments are ultimately treating our symptoms. They're not treating the disease process. And ultimately, for us to develop a cure or to move towards better therapies, we really need therapies that are addressing the underlying disorder of this condition of dystonia. And so there's converging work across multiple researchers showing that the problem with dystonia is it's a disorder of the brain, and it's a disorder of the motor circuit. So multiple regions of the brain that collectively form the motor network are not communicating with each other well. And so we understand that in order to target the disease process, we have to affect the motor circuit. We have to rewire the brain's motor circuit. And so as Dr. Tag started to explain this technology of TMS, this is a non-invasive brain stimulation technology that actually applies superficial stimulation at the scalp, and it stimulates the superficial cortex. But this technology has the power, when combined with our understanding of brain circuitry, to rewire the motor circuit. And I will show you work on our group that we have done to help demonstrate this. Now, TMS, as Dr. Tag also mentioned, is FDA approved for treatment of depression, obsessive compulsive disorder, and the reason it has become approved is because they've combined knowledge of brain circuitry with TMS to deliver TMS in an informed way that could rewire the circuitry. And so I will show you work on my end, but work preceding my group's work actually looked at TMS as a tool for studying dystonias, and particularly they were focused on focal dystonias involving the hand. And what they showed is there were 7 prior studies at the time when we started. And what they were showing is that collectively there were 2 superficial brain regions that seemed to show some benefit after TMS was delivered to the superficial cortex. These studies showed that when you deliver TMS in a repetitive way, you could get benefit if TMS was delivered to the sensory cortex or to the motor cortex. And so when we started, we actually set out to compare that. So we actually set out to compare if TMS, repetitive TMS, was delivered to the sensory cortex, and in the same patients, if TMS was delivered to the motor cortex, which of those 2 regions would show benefit, greater benefit, that could be used potentially as a therapy in the future. And we ultimately also wanted to understand how TMS works, the brain mechanism, what's happening in the motor circuit after TMS is delivered, and you get some behavior benefit. And so our overall hypothesis, or as we wanted to estimate and guesstimate, we theorized that really the area that shows benefit is actually going to rewire the motor circuit. And that's ultimately the direction we want to go, and we can use that information to develop better therapy. And so we focused also on focal hand dystonia. These are patients who have difficulty during a task of writing. And so we were looking at their writing analysis as a way to read out the behavior outcome of dystonia. So we worked with our technologists, so we worked with people in brain imaging, functional MRI, and engineering group here at Duke to develop a more accurate way to target TMS. So we actually had subjects performing writing in the scanner, in the functional MRI scanner that Dr. Berman referred to. We also had subjects performing writing alternated by rest. This was intended to bring out their dystonia, and we would then look at their brain activity as a way to identify an optimal brain target in the sensory cortex and in the motor cortex. Let me see if this works. I guess the mouse doesn't really work.
Oh, it's on my screen. I thought you were using the. Go ahead. You see it now?
All right, great. So we actually had subjects performing the writing task, and we used the activation that we see in the sensory cortex and the motor cortex. So the arrowhead shows you one subject's activated region, and we use that to identify the peak activity, which is then used to deliver a target for TMS. We then worked with our engineers in the electric field modeling to basically run some advanced computational modeling to say, how do we customize the TMS coil in such a way that we deliver personalized TMS to a region that's going to deliver maximum electricity to that brain region. So it's a personalized TMS delivery. And we then adjusted for their scalp thickness. We then adjust for their hair thickness on the day of stimulation. And on the day of stimulation, when they come, we have a target at the brain surface and at the scalp surface. We register their head to their own MRI, and we can then target and deliver TMS in a very precise way of 2 millimeter accuracy. And so these actual red and blue targets are showing you that across 12 subjects that we studied, we actually delivered TMS to the sensory and motor cortex that was across the central gyrus. And so in this trial, which was double-blinded, but all subjects received all conditions. So we did have a sham condition in our study, but subjects also received the active condition. So all subjects received all conditions, and they received TMS to the sensory cortex, active TMS to the sensory cortex. They received active TMS to the motor cortex. And then we also delivered sham so we can compare the subject's own baseline against the active TMS benefit that they may see. And it was delivered in a randomized order, and we just actually waited a week to let the signal wash out. Now, this was only 20-minute sessions. So on the day of TMS, subjects were providing a baseline behavior measure. Then they were receiving TMS, a total of 45 minutes, but it's 4 blocks of TMS, which was a total of 20 minutes of actual electrical stimulation that was done. And we delivered in a brain state dependent manner, meaning we wanted to bring out their dystonia, and then we wanted to deliver TMS so that we could activate their motor circuit and then deliver the stimulation to rewire the motor circuit. We then had them do functional MRI so we could assess the effect that it had on their brain. And then we actually measured behavioral effect as well to see before and after how much of a difference did it make in their TMS. Now, I mentioned one of the challenges of doing TMS is the technical accuracy. So one of the things we wanted to make sure was that we delivered TMS in an accurate way. So as the subjects were receiving TMS, we were actually measuring how accurate our coil position was the whole time. Every 500 milliseconds, we were recording if we maintained our target. And so we looked at the angle of the target in multiple different ways, and we asked how well did we do across the 3 conditions, which are sham, motor, and sensory. And the overall goal was to maintain the target without getting a lot of deviation, so we could say we delivered the same amount across all conditions. In order to understand the biological effects, the technical delivery has to be accurate. And so thankfully, we were able to demonstrate that there were no differences due to technical delivery of TMS across the 3 conditions, so that any changes that you may see will be due to biological differences that are happening. And so the next question was, well, how did they do behaviorally after receiving TMS? And so this is actually a behavioral readout that was developed by our group, where we were asking patients to do writing, because this was a condition where majority of the patients had dystonia during the writing task. So we would measure dystonia through their writing measures, and we would see a lot of writing disfluency. So higher measures showed greater disfluency, lower measures meant they had less writing disfluency. And when you compare it against their own sham, we started to see a significant decrease in the writing disfluency when TMS was delivered to the sensory cortex, but not to the motor cortex. And so overall, across the 12 subjects where we were comparing subjects to their own baseline, we were able to demonstrate that when we deliver 10 Hertz repetitive TMS to the sensory cortex, we could significantly reduce their behavioral readout of dystonia, which was their writing dysfluency. Now, what was surprising and unintended, but we ended up finding out afterwards, was that 20 minutes of TMS actually showed a behavioral benefit that lasted for a week. This was the first demonstration that this TMS could actually provide a prolonged benefit even after its immediate effects was stopped. So originally, TMS is believed to last for only the amount of time that you deliver TMS, but we only delivered for 20 minutes, but the effects lasted for over a week. So we are clearly doing something that may be changing the brain's motor circuitry. And so we looked at that as well and asked, what did we do to the brain circuit where TMS did show a benefit, which is the sensory cortex? And so we looked across that motor cortex that I mentioned to you before. We have superficial regions of the brain that are the cortical regions, the sensory and the motor. And then we also have the deep brain region that you've heard about today, the parietal cortex, and then the cerebellum. And so we were looking at changes in the communication between regions because that is what's known to be abnormal in dystonia. And we were looking at changes in the strengthening of the connections and the weakening of the connections. And what we found is that TMS to the sensory cortex was changing connections with the deep brain regions of the motor network. The basal ganglia, where you were seeing thinning lines, and then you had the cerebellum, where you were seeing thicker lines. So there was a rewiring of the motor circuit that we were able to see that was actually pretty significant across within subject comparisons. And then we asked, well, if we're seeing a behavioral benefit and we're seeing the brain circuit rewiring, are the two related? Is TMS driving the brain changes that is then associated with a behavioral change? And so we did this correlation where we looked at the people's individual brain activity at the sensory cortex, which is shown here on the x-axis, and we looked at the individual subject's own behavioral readout. And we asked, is the amount of change that's happening in their brain activity associated or correlated with the amount of behavior reduction we see? And so in the sham TMS, we don't see any changes because no electricity was delivered. But in the sensory cortex, where we got behavioral benefit, we see that as the activity at the sensory cortex increases, the behavior reduction goes down. So it is a direct correlation of what we're doing from TMS that is driving the brain change, which is then driving the behavior change. And so we went beyond that and we started to ask, how are the brain connections changing and how is that associated with behavior? And we then looked at connections between brain regions in the motor circuit and asked which ones are driving it. And so we looked across all the connections in the motor network and started to ask which ones are the most important and what does that signature look like? So this looks at the brain network in a cologram where you have positive correlations in red and negative correlations in blue. And the asterisks show you regions that in a sham, in the underlying dystonia, without any TMS, this is what the brain circuitry looks like, where you have certain regions of the brain that are highly associated with contributing to writing dysfluency. And these regions involve the cerebellum, the cortex, the subcortical regions. But when we do TMS to the sensory cortex, we reorganize that connections. And that reorganization seems to drive the behavioral difference that we see. And so overall, what I've shown you today is that even though TMS is delivered cortically and it provides a local stimulation, if you combine it with functional MRI and think about the motor circuitry, you can rewire the brain in a very powerful way. And so we cortically delivered 10 Hertz TMS in a very technically precise way to the sensory cortex. And we were able to see that we could reduce dysfluency within subject compared to their own sham. We were able to show that we can make connections to deep brain regions of the motor network and that these brain region correlations are driven and associated with each other, and that could serve as a brain signature for behavioral improvement in other clinical interventions. And now we're actually planning this out as a clinical trial, a prospective clinical trial. So we're currently actually recruiting patients where they're going to receive not only one session, but 4 sessions in a single day. And so the way I imagine TMS being a clinical therapy is that patients come into clinic similar to their botulinum toxin. They receive a whole day of TMS, 4 sessions, 9 to 5 schedule. And that effect hopefully will last for a few months. So we have actually started recruiting subjects for this accelerated TMS study. And the concept behind is called metaplasticity, where you let the brain circuit start rewiring in a way that goes beyond what TMS delivers. So once you start the process of rewiring, it continues beyond after the immediate effects of TMS are gone. And that's what we were trying to click into when we delivered TMS. We wanted to link into the brain's underlying plasticity pathway. I'm guessing that's a, okay. So that's it pretty much. And if you're interested, I work with a team of great people, and I also have the QR code in case anyone would like to learn about our study or have any questions. So thank you so much.